Okay, so good evening, everybody, and welcome to our webinar, Veterans, Headache and Migraines. It's really an important topic this month because it is Migraine and Headache Awareness Month. And for more information, you can go to CHAMP, which has a whole schedule of events this month. But this evening, we have an exciting panel of veterans that have been dealing with headaches and migraines, and two medical professionals that specifically work with people with migraines. So first, the agenda for this evening is we're going to go over some housekeeping items, and then we'll have the presentation and questions and answers. So the program will be around an hour to an hour and a half, just so that you can judge how long you'll be on the call. Okay, so all questions will be taken at the end. Note that we cannot answer highly specific medical questions. To ask a question, if you're on Zoom, type it in using the Q&A icon at the bottom of your screen. If you're on Facebook, please type it into the comments. The chat is open. Please be respectful of one another. All webinars are recorded and posted to uspainfoundation.org webinars. And now a disclaimer is this webinar is educational only. The information is not meant to take place of your healthcare provider. You should always consult with your doctor about your unique health situation. US Pain does not recommend or endorse any one therapy, treatment, or product. So I have the pleasure of welcoming Dr. Emmanuelle Schindler and Dr. Elizabeth Singh. Dr. Schindler is a medical director of the Headache Center of Excellence at Veterans Affairs Connecticut Healthcare System and assistant professor of neurology at Yale School of Medicine. Among her efforts to optimize the management of headache disorders, she has expanded the options for the treatment of refractory headache at VA Connecticut, and she has developed and executed clinical trials investigating a novel preventive agent. Dr. Elizabeth Singh is a headache psychologist and the Deputy Director of Research and Evaluation Center for the VA Headache Centers of Excellence. She is also an associate professor at Yeshiva University and Albert Einstein College of Medicine, where she and her lab use mobile health tools to understand migraine precipitants and test behavioral treatments. And then just to introduce our veterans, please. Yeah, okay, so this is the great veterans that we're having here tonight, okay? So we have Kate Benson. Kate is Coast Guard veteran and a trained US Pain Foundation leader. She spent 12 years serving in the Coast Guard before thyroid cancer, chronic migraine, and a painful condition called trigeminal neuralgia, but an unexpected end to her military career. Kate leads Pain Connection's basic training for veterans with pain support group. Okay, and Cheryl McJoy. Cheryl is a veteran of the US Navy who will be featured in the upcoming issue of US Pain's flagship publication, The Invisible Project. Cheryl was diagnosed with chronic headache and migraine after falling while repairing an engine on a P-3C Orion aircraft in Okinawa, Japan. And next is John Abel and his amazing fish, right? I mean, it's an amazing fish that he caught there. John is a Coast Guard veteran who has been serving for 20 years and is still active today. And I think he said he only has 341 days left, but I don't know, I'll let him correct me a little bit later on. He started getting migraines in about 2000, but they were undiagnosed until 2017. Today, he receives medical treatment from military doctors and believes his migraines to be managed. And that is our excellent panel that you're going to be hearing from today. And I'm Gwenn Herman. I'm Clinical Director of Pain Connection Programs for the US Pain Foundation. So let's get on to these presentations. All right, so we're going to start with our veterans first, and I'm going to open up with Cheryl McJoy. So Cheryl, would you like to introduce yourself and just tell us, about what made you go into the military and what happened to you there and how your chronic pain started. That would be wonderful.
Hello, everyone. I am Cheryl McJoy, Big J for lots of joy. I am 20-year retired military, world's finest Navy. My chronic headache journey started in about 1996 when I fell between 10 and 16 feet off a P-3 Orion. We were changing an aircraft engine. Back in the day, everyone was given vitamin M, which all of our veterans know is Motrin, right? And continue to have these chronic headaches or migraines, no diagnosis, just kind of given everything but what I needed. And through lots of fighting, finally got it diagnosed with a TBI, which is traumatic brain injury that I suffered falling off of the wing of that aircraft. And from there, once I received the diagnosis, I was able to learn how to manage it in a way that didn't require me to be a zombie every day. So, and I'm so happy to be here with you today.
Thank you, Cheryl. Thank you very much. Yeah, Kate, would you like to tell us?
My name is Kate Benson. As Gwen said, I am the group leader for the Basic Training for Veterans with Pain group. I was active duty in the Coast Guard for almost 13 years. I got thyroid cancer, and with that, the second surgery that I went through, I got trigeminal neuralgia and started suffering migraines because of the pain with trigeminal neuralgia. And I still suffer through them today. And I manage my pain with marijuana.
Thank you. Yeah. John, would you like to tell us your story?
Yeah, I joined the Coast Guard right out of high school in 2001. And like I said, I'm almost 20 years in. I retire next year. Yes, you were correct. 341 days. Let's see here. I started having issues back around 2003 or 4, I think, when I left A school. Don't know what started it. I didn't even know I had migraines. I just thought they were headaches, and I just sucked it up till about 2015, when my wife, who's much smarter than me, and she's listening in the background, said, "That's not normal. Go to medical." I went to medical, and they said, "Yeah, you're messed up in the head, basically." And they originally put me on Topamax. And that did not work at all. That gave me all kinds of side effects, including it was horrible. They sent me to, where did they go? J-Bear, which is joint base. It's joint base up in Anchorage. I was in Kodiak, Alaska at the time. And the doc there said, "You sound great for our Botox trials." So I said, "Sure, stick me in the head." So she stuck me in the head with like 25 or 30 injections. And a couple of days later, I started feeling a lot better. And they had me on a 10-week regiment there. Here I'm going to Portsmouth Naval, and they have me on a 12-week regiment here. And I definitely notice when it starts wearing off. I start getting seasick more often, and my motion sickness starts getting worse when it starts wearing off near the end of my injection cycle. And then actually tomorrow morning I go to get a refresher. They'll stick me again tomorrow morning, but it seems to be working fairly well.
Thank you for that. Yeah. And Dr. Schindler, can you tell us, what you're doing at your workplace?
Sure. Thank you, Gwen. Yes, so I'm the medical director of the Headache Center of Excellence at the West Haven VA Hospital, and would you like me to share my slides now or a little bit later?
Wait, let's, let me, why don't you just introduce yourself, and we'll go to Dr. Seng, and then we'll come back, okay? Yeah.
Sure, okay. So at the Headache Center at the West Haven, Connecticut VA, we've been developing a couple of different ways to help manage headache in the outpatient clinic, in the hospital, outpatient infusion centers, and we have a multidisciplinary approach where we have a lot of different subspecialties also involved with headache management, knowing that headache management is not only drugs, but also a lot of self-management and non-pharmaceutical care.
Thank you, Dr. Schindler. Yeah, Dr. Seng.
Hi, so I'm the Deputy Director of the Research and Evaluation Center for the Headache Centers of Excellence. And just, you'll always hear everybody at the VA saying this, but Dr. Schindler and I are presenting our own views and opinions. They don't represent the views and opinions of the United States government. So we're very interested, as Dr. Schindler mentioned, in exploring how to both get effective multidisciplinary approaches to patients and how to make sure that patients are identified early, get aggressive, appropriate treatment, and then are supported in kind of continuing treatments that they find to be effective. We're also just frankly trying to figure out overall how many people have different headache disorders in the VA who have we not identified yet, where are the unmet needs, and how can we try to meet them. And what we have found, as Kate is alluding to, is that there are lots of unmet needs. So there are groups of people working very, very hard trying to figure out the communities that are currently underserved by the VA and to get appropriate treatments to those communities.
Thank you very much. So just a question to the veterans on the panel. Is there a headache center in your area, and are you able to get there? Cheryl? Not in your area? Kate? Not in your area? John? Not in your area?
I don't have one in my area. My VA is actually 58 miles away. So marijuana.
Okay. And we'll talk about that in a little while. Yeah, definitely. Okay. And is there a stigma for the veterans around mental health and going for help and asking for help? John, I'll start with you.
Yeah, not that I've seen. I've worked with I did a lot of work with Wounded Warrior Project when I was up in Kodiak, and I do a bit down here. And if there's a stigma there, I have not seen it nor noticed it. And these guys, and usually the guys I work with, have no problem saying if they got TBIs or, most of us are crazy to begin with, but I've never seen anybody have any problems sharing their issues.
Okay, thank you. Yeah, Kate, you were shaking your head, or?
I'm laughing at John because we don't all have mental problems.
Speak for yourself.
I was going to say, we're expected to be in top physical and mental condition at all times. So to admit that something might be wrong, especially something that a supervisor can't see, is very difficult. And not everybody believes in depression. Not everybody thinks that is a real thing, an actual chemical issue. You can smile and get through that, is what I've been told. You can suck that up and keep moving forward. You can deal with therapy on your time off, is what I was told during my time. Cheryl, is that same for you?
Yes, I think, well, from my experience, I think John's experience is probably an anomaly, because part of being in the military is being a warrior and having that warrior mindset. And warriors don't get sick, warriors don't have diseases, warriors don't take time off. You just push through, right? Or you just take some Motrin and you just proceed to do what you have to do. And the perception, from my opinion, is that you're weak-minded if you can't handle the small things, such as who's ever had a headache that will keep you at home, right? Or you're told, hey, you've had cramps worse than headaches, so why can't you show up for work?
Okay. Yeah, thank you for, being honest with us and looking at the different experiences, that you've all had. So where do you go for your emotional support when you need it?
I'll answer the question first. So for me, the emotional support, I just want to say that for me, that was the most difficult battle of my career in my life, being able to say that I need help, especially emotional help, and also being able to find the things inside of the medical care system that I do but my family, my faith, my friends, I have a great support system that can lift me up. Reading, writing, I find hobbies, I travel, being able to find those things that I love, the things that I dream about. Those are the things that I do and I find for emotional support, and also finding people who have similar issues to mine. They may not be the same, but who have similar issues that can relate to some of the things that I go through on a day-to-day basis, and people that don't judge me. That's what I do.
Okay. Kate?
Similar things. I find support in my family and in my friends. Unfortunately, I think a lot of veterans don't have family support, don't have good friend foundations, so they turn to unhealthy support like alcohol, even things like going to the gym all day, every day. That can be unhealthy. Substance abuse, drug abuse. Of course, not drug abuse while you're in, but if you don't have the right things in place, then you turn to unhealthy things.
Okay. And for you, John?
You know, until I got married here a couple years ago, it was always just, I'd disappear for a couple of days. I'd go up in the mountains, and Kate knows that extremely well. We were stationed together for a while. I'd disappear. I was either on the boat with my dog, or I was in the middle of nowhere chasing some critters with my dog. That's how I got through everything. It's still do to some point. I'm always on the boat working on something, but I got the wife and her dog now. So yep, that's what I always did.
Okay. Hope your wife likes the critters. Yeah. So we were talking about, if there's a headache center near you, and, what do you do for emotional support? So I was thinking maybe let's just go to Dr. Schindler now and tell us, what is the headache center? What makes it so special? Why does the Veterans Administration really need it?
Oh, great. You have my slides. Yeah. Yeah. So this is just my intro slide. And I have here just a snippet from the taking some of the language from the legislation that stated that there's a great need for specialized headache care within the veteran population. There's a mention, of course, of the high number of traumatic brain injuries in the military. Headaches don't have to only emerge from TBI, but there are also a lot of TBIs within our service members and our veterans. So that was certainly noted, and over recent years has been a signature type of injury. And head injuries don't only involve direct injury to the head or hitting your head on something. It can be exposure to forces such as explosions or sounds. And so that's being recognized as well, not just blunt head injury, and not only injury that results in a cracked skull or something worse, but even mild TBI. Actually, mild TBI is most common and has a very high rate of having headaches develop afterwards, along with a constellation of other symptoms, which is known as post-concussive syndrome. So the recognition of that was central to having the headache centers of excellence come into being. And this is a recent thing. So it only began in 2018. And there were, and actually, if you go to the next slide, this map is about a year plus old. I'm happy to say that there are more of these blue and yellow bubbles. The pink bubbles are the VAs, and the size of the bubble is showing how many veterans are being served in that area. As was mentioned before, how many miles you have to go to get to a VA. You can see that there's this Northeast cluster and there's little clusters, but in the square states, there's not. You have to go hundreds of miles to find a VA. And the blue spots, these are the central headache centers. So West Haven is there on the top, and there are five others. The yellow ones, there's actually more of them now. These are consortium sites where they are part of the headache center. They don't have all of the facilities of the blue dots, but we have 7+ of these yellow dots now. So again, this is an outdated graph. And what the headache centers, what they contain are neurologists and physical and rehab medicine physicians, TBI centers, mental health services, multiple subspecialties who are recognized to be vital in managing headache patients. And if you go to the next slide, this is a chart looking at the number of veterans with a specific headache disorder within this 10-year span, and just showing the sheer number. We're most familiar with migraine headache, and we probably have heard of tension type headaches too. There are these less common types of headaches where the numbers are a little bit smaller. And this NOS stands for not otherwise specified. So a headache type that couldn't be diagnosed, which I think a lot of patients have been told, oh, you just have headaches, and they're lumped in this category of chronic headache. And that's not very specific. Each headache type is managed differently. So it's important to know. So a large number of these patients were in this not otherwise specified category. And that's not helpful because you really have to understand the headache disorder in order to actually treat it. And the next slide, this is my last slide. This is in the corner is the heading of the International Classification of Headache Disorders, which is the Bible of headache disorders. This is where we go to help in the diagnosis of headache disorders. These first 7 pages is just the table of contents. So each line on each of these pages is a different headache disorder. So it's not just migraine, it's not just tension, it's not just NOS headache. You have to specify what headache it is because the treatments are all different. How it affects patients is all different. So you need specialists who know about headache. To know these 7 pages takes a lot of training and a lot of patience, and so we think that every veteran deserves that, to have exposure to have access to centers who know the difference between all these different headache types and how to manage patients. So yeah, I think that's my last slide.
Okay, can we go back to the previous slide for a second, please? Yeah. So I was just wondering, because when you look at the numbers, the percentage, the women have higher percentage. And is that because women are more likely to admit that they have an issue and men hide it? Or what do you think the discrepancy is?
No, this is roughly consistent with the prevalence in the general population. So for migraine, for instance, it's about 3 to 1 more women versus men. So it's about it's roughly equal. In the general population, women, it's about 18% have migraine. So it is possible that fewer women are actually coming forward and saying that they have migraine because this number is a little bit lower than the general population.
Okay. And I think in a previous discussion, you said before 2018, there was only 3 doctors that were handling all these people, right?
Yeah. So yeah, in the first slide, yeah, this was back in 2018. So headache medicine is its own subspecialty with the board certification. And at the time that the headache center was first developed, there were only 3 headache medicine boarded physicians within the VA system. So that number has more than, I think, tripled now since, and I'm one of them now as of so, so that's what we are seeking, is those who are headache medicine boarded. But that's a board certification for physicians. But there are other types of certification for headache specialty for PAs, nurses, other practitioners as well. So that's what we are seeking. And headache is one of the most common symptoms that someone goes to a neurologist for. So a lot of neurologists, just by sheer practice over 20 plus years or so, have seen a lot of headache. And so there are mechanisms that they can be, they can be recognized as, as a headache expert just because of their sheer exposure, or that they do research in headache as well. And that's another, that's one of the other, that's another focus of the headache centers is to do research. And Dr. Seng touched on that in her intro. We don't just want to start throwing the old meds at the patients, because especially post-traumatic headache, which is a big issue within the VA. There are no FDA-approved medications for post-traumatic headache. So how we manage it now is we just use the migraine meds, or we try some other medications, but there really isn't any targeted therapy for post-traumatic headache, which is likely going to be a combination of different therapies, again, pharmaceutical and non-pharmaceutical. So we do have research going on looking specifically at patients who have a post-traumatic headache, and we're excited because we're one of the only places looking at that. There haven't been very many studies of post-traumatic headache, and we're poised to do large studies to see what treatments work. So so a strong clinical component and a strong research component are very important to the headache center.
Thank you so much. And going to Dr. Seng, what's your view on everything, or at your work, what are you more focused on?
So my goal is to help guide the research of the headache centers of excellence. So there are a handful of things that are just foundational to be able to understand the burden of headache in the VA. So for example, we don't even really have a good way of measuring the burden of headache. Migraine outside the VA, migraine has gotten by far the most attention. Migraine is, by some estimates, the second leading cause of disability in the world. Migraine, hits people during the prime of their lives when they're supposed to be starting families, starting their careers, getting everything up and running. Instead, they experience significant occupational and social disruption because of these unpredictable, painful neurologic attacks. And obviously, migraine is a big problem in the VA, and that's one of the main pieces of the pie that I am personally biting off to try to start to understand who has migraine, what do they look like, how does it look similar and different from outside the VA. But as Dr. Schindler alluded to, migraine is not the only problematic headache type, and migraine is not the only problematic headache type that is likely highly prevalent in the VA. Post-traumatic headache and post-traumatic headache that may look a lot like migraine, or migraine that is exacerbated by traumatic brain injury, are likely highly prevalent in the VA and are likely undercoded and difficult to exactly tease out in the electronic health record, which is one of the reasons why you see that astronomical number, over 1 million people diagnosed with headache not otherwise specified, which is not a real diagnostic category. So our goal is to both, so outside the VA, most of the measures of headache burden are actually measures of migraine burden. And that's not a bad thing. That's a great thing. And I'm very grateful for all of the, academic and industry partners who have developed those measures. However, they aren't appropriate for the people we see and the people we're working with. So you just can't take some of these measures and give them to someone who's suffering from cluster headache, which is one of the most painful things somebody can experience, and have it translate and make any sense. So Just as a small example, we are working towards developing a veteran-centric measure of the burden of headache disorders, because if we can't measure it, we don't know if we're making it better, and we don't know, where to target new centers and how to. So we're working on things as simple as measurement. Another thing that we're working on is trying to figure out who has headache. Where are they? How far are they from a headache center? How far are they just from a neurologist? These are important questions. And the numbers that Dr. Schindler showed you are too low, just based on what we would expect from the population prevalence of migraine, for example, is 18% of women and 6% of men. These are at least a third to a half lower than we would expect. So there are likely hundreds of thousands of patients, if not over 1 million patients, who are presenting to the VA for care, but who have not, at least in the last 12 years, received a headache diagnosis of any type. So we want to find those people. We want to find them and develop effective treatments, and then be able to offer those treatments to patients who need them.
Thank you very much. So it leads me to the next question, is that, so when you have somebody coming into your clinic, what's the best way they can present their issues, or how can they describe their headaches to you that would make your job a little bit easier?
So I'll start, and then we'll move to Dr. Schindler. So I'm a headache psychologist. So one of the things I actually help people with is doctor-patient communication, because I get more time than Dr. Schindler does. So oftentimes I get a whole bunch of a story, and there may be a whole piece that people just never thought to tell their neurologist or did. So I think one of the big things that I would say is that remember that headache disorders are not only headache, and you may be experiencing a whole bunch of symptoms. And it's not your job to figure out which ones matter. And it's not your job to figure out which ones go together. Dr. Google is probably not your best friend. Hopefully your VA doctor is. But it really helps to write it down. It helps to keep track. You don't have to keep a headache diary forever. This is something that I think people get this idea that they have to keep headache diaries forever. Like, toss that out of your mind. I don't like it when people keep headache diaries that long. It can make you anxious, and it can just increase the burden in some ways. But the 30 days before you go see a headache specialist, take a headache diary. Write down your symptoms, write down everything that's happening in and around those attacks, because there may be things that make the neurologist say, oh, I have an idea that you never would have even put together were part of your attacks.
Thank you very much. And Dr. Schindler?
Yes, I also agree. I don't want patients to keep a headache diary, and I don't want them to come in and drop, reams of paper on my desk and have me look through. I don't do that. The reason that the headache diary is helpful is that those 7 pages of different headache types, they're all different, and the way that we tell them apart is where is the pain happening? What side of the head? Is it on both sides? Does it come on like a lightning bolt, or does it gradually come on? How long is it? Does it last all day, or does it last 10 minutes? How many times a day is it happening? Do you have any other symptoms with it, like nausea or light sensitivity? Teasing out all of those little details helps me know what treatment's going to work and what treatment is not going to work. Dr. Seng mentioned cluster headache, which is it is a severely painful headache type. And I can't tell you how many patients have come in with a migraine diagnosis and they've had cluster headache the whole time. Migraine medicines do not work in cluster headache. And just to put things in perspective, cluster headache is also known as suicide headache because the pain is excruciating. Patients think about harming themselves during the attacks, after the attacks. Just thinking about the next attack makes them want to not be around anymore. and to misdiagnose someone with cluster headache with something else is really robbing them of their quality of life and the socioeconomic well-being, interpersonal well-being. And I'm just using cluster headache as an example. Migraine can also obviously rob someone's life of their socioeconomic well-being and interpersonal well-being. And it can be, it's not even, I don't even think it's that subtle. Cluster headache is very, very distinct. And no one bothered to ask the question, how long are your attacks? Do they happen certain times of year? Those simple questions should be asked, and they're unfortunately often not. And so I think, giving as much detail, whether you think it matters or not, can really help, because the way that we distinguish headache types is by those details. And you might be annoyed every time you get those questions again. And I always, when I get a new patient, I don't care if they walk in with a diagnosis of migraine, I want to verify it, because half the time it's not correct. And just the other thing that I'll mention is that while people's experiences might be different, I would say don't be shy about it. We're there. We don't. Or I guess you don't have to convince us that you have headache, because headache is one of these things where, unless you're having it, well, even if you are having a headache in front of me, I can't tell, because you look the same. Some headache types, you may have some physical symptoms, but you don't have to convince me. I believe you automatically. And I think that a lot of patients go through several doctors where they don't believe them. Oh, it's impossible for you to have this many headaches, or for you to have lost your job. That never happens. You don't have to convince us. We already believe you walking in the door. So feel free to tell us all the ways that headache has impacted you, because that also helps us know, okay, they'll do okay with some Botox and some triptan, or, oh, this person needs a lot of support, and let's get them to that, to those people as soon as possible. So tell us everything.
Yeah, thank you so much. So going to the veterans now, of how do you advocate for yourself? And this question is really, Cheryl had raised this up when we were in a practice session, of advocating for yourself to the doctor. Cheryl.
All right. The first thing is having clarity on what you need. That's the main thing. Understanding that this is your body. You know what you deal with every day. When you, as Dr. Schindler said, do you need psychological help? Is it nutrition? Because so many things are triggers, and so many things, do you need job help? Because if you're in a job that's that's causing or that's triggering your headache. So these are some of the things that you think about as far as what do you do? And then also being able to say that you need help when you go to the doctor, to not go in and to be so strong that when the doctor asks your question, it's fine. Everything's all right, because you've been burnt by a couple of other doctors. So advocating for yourself, understanding your needs, know exactly what you need in every area of your life that you need, whether it's spiritual, mental, physical, financial, whatever. Being able to ask for help. And then also asking for resources that are available there at the VA and then outside of the VA as well. And doing your research before you go to the doctor. And having a list of the medications that you take, what you've taken, what did it work, what were your symptoms. Because if a doctor tries to put you on something that you've already been on, or a drug that's similar, then you're just taking 3 steps back and you don't want to deal with it anymore. So, and then also just understand that it's an uphill battle. So don't go in with the expectation that the first doctor that you see is going to solve your problem. You have to be willing to stick through it until you find that one doctor that listens to you and can get you the help you need. Being an advocate for yourself, you got to be a bulldog.
Great, Cheryl. So what about, did you ever bring in a family member or a significant other to help you? Because I know I have chronic pain myself, and a lot of times when I would go to a doctor's appointment, if I was in such a bad state, I would bring my husband with me, because a lot of times I'll get hurt by what a doctor says to me, or I just may get so vulnerable that I can't think. So I don't know if you've ever done that, to bring somebody with you to an appointment. Oh, Cheryl, I was asking.
My checklist. That's the thing. Have my
Okay.
checklist. So even if I bring a family member or a friend or whatever, we each have a checklist. And if I forget to ask the question, you make sure that I ask the question. And I don't care how the doctor rushes you. So that checklist is like, that's that's like your bae when you're at the doctor. You just be like, that's bae. Having that checklist to go over the questions with your doctor. And then for things that you forget. Because when you get in there, that 5 minutes you have with the doctor, I promise when you leave, you're like, dang, I should have asked. And
Yeah.
then maybe once or a year to your next appointment.
Yeah, thank you, Cheryl. That was great. Yeah. John, what about you? But how do you advocate for yourself when you go to the doctor? Like, how did you
So-
get the Botox? Did you ask for anything or?
No, so when I haven't had, so it's kind of weird for me sitting here because I haven't had the problems that Katie and Cheryl, right? It's Cheryl. I
Yeah.
haven't had the issues that they've been stating here. But it could be because I'm active duty and I haven't had to deal with the VA. You know,
Oh.
I've heard that can be a problem. I don't know, and apparently Katie is telling me just wait. So, so like, when I went to get diagnosed, I showed up because my wife told me, stuff wasn't normal. And I went down and talked to my docs who I knew very well in Kodiak. I was there for a long time. And they said, yeah, it sounds like you're suffering from migraines. And they said, we tried the Topamax, it didn't work. And they referred me up to a J-Bear where they had a neurology clinic. And I went up there the first time and I sat down with the doc there. She was a major. And she went over, and this was 4 or 5 years ago. I don't remember it all completely, but and I just told her what my problems were and what problems I was having, and that's when she recommended the Botox, and I said sure, as long as it goes away. And the only problems I've had since then was when I transferred over here, finding a Botox clinic, and I just dumb lucked upon finding that Portsmouth Naval here has it, and hopefully. I've talked to them because I'm getting ready to retire here, and they said, no, once you're retired, you can keep coming to us.
Oh.
So I've kind of gotten I'm seeing that apparently I've gotten extremely lucky because my diagnosis for what they've put me on was good right off the bat. I don't really have any serious side effects from it. As long as I do got to watch my diet, and I've mentioned that to them, but the stuff I've mentioned to them, like, wheat, heavy carbs and stuff like that, that cause problems. But apparently I'm a abnormal case, I guess, or it's because I'm still active and I have easy access to medical.
That's great. Well, you raised a great point about the difference between treatment for active and veterans. Yeah. And maybe, the doctors, we can talk about that afterwards. But Kate, what's your experience about advocating for yourself? How do you prepare?
Before I jump into that, I will say, being new to this medical retirement, I will say, as an active person, the doctors do everything in their power to get you moving as an active person again, because they need you in the field. And as a retired person, to send you back to your couch, I wish I was more like Cheryl. And I wish I could go in there like a bulldog. But I got burned right when I got out by several VAs in the DMV area, which is Virginia, Maryland, DC, this area that it's embarrassing, but I'm 4 years and I haven't seen anybody.
Oh, that's unbelievable.
I know, it's really, I never thought to take a family member because, medical it's a private thing. It just never occurred to me, I guess.
Thank you. So moving back to Dr. Seng and Dr. Schindler. Okay, so here they come. New patient comes in, and hopefully they have this diary, a 30-day diary. But is there any way that when somebody has an appointment that they can be told to do this 30-day diary before they see you? I mean, is that part of the protocol or no?
Well, as of right now, we haven't, when we make the, when we get the referral and we make the appointment, we haven't been having people keep the diary. Sometimes we have very, somewhat urgent appointments and we see them the next week. So obviously that's not going to work. So we haven't been having people do it ahead of time. we usually ask them after the first visit, but we could start trying to trying to have, when we schedule, ask patients, hey, can you start keeping a diary? That will be because that would be helpful.
Yeah, and Dr. Seng?
It really depends a lot on the clinical setting. So one of the things that I think is most important to know about headache is it's not just that relatively few, very few people have access to a headache center. But even beyond that, relatively few people with headache disorders make it all the way through to anyone beyond primary care. Yes, there is an urgent need to optimize care for those who make it all the way to a center. But there is also an urgent need to provide a high quality base level of care to every person in the VA who presents to their primary care physician at their annual visit with headache symptoms. And there are a number of initiatives, both within the VA, outside the VA, with professional organizations, foundations, and partnerships between professional organizations, foundations, and the VA to improve education at the primary care level, resources at the primary care level, so that more people have access to high quality headache care. Because if you just think about the numbers we're talking about, right? So just migraine, at minimum, 18% of women and 6% of men. That's so many people in the VA coming through every year, right? So only a small proportion of those people with the most disabling disease are going to make it all the way through to a headache center. So it's really incumbent upon us in the system to try to raise all boats, right? Increase the level of education and access to care across the board, so that people who have more straightforward disease to manage are managed appropriately at the lowest level of care, and that we are able to quickly move through whether that's not going to work, time to get you to the headache center, right? So we need to think about it from kind of both angles, and those are certainly things that we're working towards.
Okay, thank you so much. So going back to you, Dr. Schindler. So what are the actual treatments you have to offer to your patients?
We have a lot of different things. I wanted to make a quick point about the last comments too, if I could. So finding good headache care is hard, even outside the VA. There are, I think, fewer than 2,000 headache boarded doctors in the U.S. So, we have a dozen or more now in the VA, but 2,000 for the whole country. So, and they also tend to cluster in the more urban areas as well. So it's hard. Finding headache care is hard everywhere. And a lot of patients go through with misdiagnosis. Why it's so important in the VA is that there's so many, because there's also head injury and other physical injuries that lead to chronic pain in the body that can then sensitize the whole system and make headaches worse. The headache doctors who work there really have to know about those other conditions. So it's hard everywhere, and we have to do better everywhere, but we especially need to do better in the VA. So, but happily, we do have a lot of different treatments once you find us. So there are, of course, the good old-fashioned chemical ways to manage headache disorders, and it's important to also distinguish the treatments that treat one single headache attack versus treating the underlying disorder. For instance, there are some headache disorders caused by increased pressure inside the brain. So you could take Motrin every time you have one of these headaches, but that wouldn't treat the underlying cause of the headache, which is the increased pressure. So medications like Topamax can actually decrease pressure in the brain by actually decreasing how much brain fluid your brain makes. I know I'm going into too much detail here, but
no, it's great. No, this is great. Yeah.
So there are medications that are used to help treat the underlying cause of headache. And for some of those conditions, there's no way around it. It has to either be a drug or some kind of surgical procedure. Again, thinking of the low or the high pressure in the brain, that's going to involve some kind of medication to treat the underlying cause. And there are numerous treatments, those that you take every day, things like the Botox, which are administered once every 3 months. We have new medications that have come out on the market that are injections that are given once a month that help decrease inflammation in the body. That is related to different headache types. And then we also have non-pharmaceutical ways to help both treat a single headache or treat the underlying disorder. We have neuromodulation. So these are devices. There's a vagus nerve stimulator, a device you hold up to your neck, and that stimulates the vagus nerve. The vagus nerve modulates a lot of different functions in the body and can help turn off those pain signals. That's just one example. And then we in our visits with patients, we ask about diet and sleep and other such things. Sleep apnea is a big big trigger and for headache for headache. So assessing people for sleep apnea, insomnia, poor diet, dehydration. There's a lot of just lifestyle things that can help as well. So we counsel patients on that as well. And then sometimes there's only so much you can do in terms of how much of a reduction in the headache burden you can get. I always I try to put this lightly, but there's not really a cure for headache. Headache disorders tend to go into remission over time. And in some cases, when there's something causing it, like a malformed blood vessel or something, you can take care of that and the headaches go away. But because headache disorders are something genetic and they're triggered by things in the environment, and they're conditions that sort of stay with you. And what I like about treating headache is that my goal is not to get zero headache, because that's really, really hard. The goal is to have as few headaches as you can, have them be less intense, have a good treatment regimen, so that if you do sense one coming, take something right away, and you keep it from turning into one of these monsters. But it's extraordinarily hard to go to zero headache. So knowing that people will have some level of pain left, and some type of disability, it's important to also have patients learn how to manage that. So we in our headache center, we work closely with a health psychologist who sees patients and helps them manage. Okay, how do we reduce stress to keep you from having more headaches? Because we know that you have a genetic condition that predisposes you to getting headaches. So we can't change your genes. So let's manage the things around it. So having those other services available, and I can list a bunch of other things, like we use acupuncture. We have access to we're going to be starting biofeedback soon. We're thinking about expanding into things like medical hypnosis. There are a lot of different ways to help manage what pain and what disability you have left after we really try to maximally manage the headache disorder.
Thank you so much. And going to Dr. Seng, so what are the treatments that you do with your patients?
Yeah, so I'm a health psychologist,
Yeah.
and I think that health psychology is one of the strengths of the VA system. So, in a system where the goal is to take care of human beings rather than to bill for sessions, health psychology makes a lot of sense. So, the VA has invested heavily. Every single primary care has a health psychologist integrated, and every headache center of excellence has a health psychologist integrated. So, it's a special kind of psychologist whose goal is not necessarily to help with depression, anxiety, post-traumatic stress disorder, although we can do those things when needed. The goal is to help treat medical illness through either reducing the illness itself or improving quality of life related to the illness. So when somebody is a health psychologist at a headache center of excellence, their first goal is to try to look at lifestyle and say, if not every headache disorder is affected by lifestyle, but some of them are. And if you have a headache disorder that does have a relationship with lifestyle, we look at your lifestyle and say, okay, what does your stress look like? What does your sleep look like? Did having high stress or poor sleep cause you to have the headache disorder? No, that's incredibly silly, and it just increases stigma and, quash that immediately, right? These are genetic conditions. They interact with your early life environment, and here you are. Like there's nothing that you could have really done differently. To this point, you have the disease, but now that you have it, that means that we should be optimizing your life to try to reduce your symptoms. And that means living a very, very, very consistent life, waking up at the same time, going to bed at the same time, eating meals on a pretty routine schedule, not skipping meals, staying well hydrated, and as much as you can, trying to manage stress, although that's really the kicker, right? So these are not easy things. They're not easy, and that's why we have people embedded in every single one of these centers to try to help optimize these pieces. And then for every headache disorder, regardless of how much lifestyle might actually be associated with attack onsets themselves, they can all contribute to disability and poor quality of life. And learning how to cope, that can be a lifelong project, right? So oftentimes those treatments might go a little bit further afield. They may include things like mindfulness-based approaches can be very, very helpful. It might also include groups. Speaking with other people who are going through something similar to you can often be really, really helpful to help give you some good tips for how to deal with stuff, and to, kind of see how other people are trying to live their best life while also dealing with a disabling disease. The last thing that we do relatively frequently is bring in family members, because headache disorders are invisible. And when you haven't experienced it, it can really be very difficult to understand how problematic they are. So for many people, the stigma actually starts at home. And your family members may not necessarily be your best advocates because they may not really fully understand what's going on with you. And sometimes having some family visits with a health psychologist can help everybody see ways in which their attempts to help are actually hurting, ways in which they could improve the support of the person with a headache disorder, and ways that they can help advocate for their family member in the broader community. So those are the main kinds of things that you might experience if you were to see a health psychologist, either the health psychologist embedded in your primary care or embedded in a headache center of excellence to receive headache care.
So do you have support groups, or do you call them support groups? What do you call them, your group?
So I have specifically run some mindfulness groups, and I've run some health education groups. We had implemented at a time in the West Haven VA a 4-week kind of learn about your headache education group. And I don't know if there are any groups currently running, but I know that that's certainly something that is in the, the ethos that we have certainly considered bringing back. It's
Okay.
also COVID right now. So bringing large groups of people together in person has not really been possible for the last year and a half.
So how is telehealth maybe advanced, a lot of treatment, since there's so few centers around and people live far away from the VA? Has telehealth helped at all?
Yes. So let me give a broad overview, and then maybe Dr. Schindler can speak more directly to her experiences just in this last year. So the VA has actually, in some ways, been a leader in telehealth. So some of the earliest telehealth, in part because of licensing requirements. So when you work at a VA, you only have to be licensed in one state, and then you can work in any VA because it's considered federal property. So if I were to move to Texas, I would need to get licensed in Texas if I wanted to work anywhere else, but I would not have to get licensed in Texas to work at a VA, which increases the feasibility of doing telehealth. So for many years at this point, over a decade, the VA had a telehealth service where a super specialist sitting in a large urban area could from their office, could tele into an office in a very rural area, and you could get access to super specialty care. So you would still have to move your body to a VA, but the VA could be the closest one to you. At the time, I did some of that early on, and it was amazing. And we all thought we were very cool. And now, of course, this is ridiculous. People still live very far away from their VAs. It is not easy to get your body into a VA. Parking is a real thing. So is traffic. So, more recently, and certainly the pandemic sped up the ability to do telehealth directly into people's homes. There are things that make that a little bit more difficult. And there are pieces of an exam that are really quite difficult to do over telehealth that can be really, really critical for understanding headache disorder diagnosis. So for many first visits, we're still really trying to see people in person as much as possible. And the nice thing about that first version of telehealth, where you come to your own VA, is that there's a nurse who sits there and can participate in pieces of the physical exam. If something comes up and you need to be taken to the emergency department, the nurse escorts you. Things like that, where, if you're on your couch and I think, gee, you might need to go to the emergency department, that's just a little bit of a harder task. So we have certainly, there's been a huge shift to telehealth. At the same time, I think that there's a lot that is really helpful to see people in person. And it's one important reason to increase the number of subspecialist headache physicians who are available in the VA. But Dr. Schindler, I would love to hear a little bit about your personal experience in the last year.
Oh yeah, I was actually just building my own telehealth clinic right before the pandemic. So I hadn't opened it yet, but it was being built. So I felt like it was meant to be. But yeah, it has really helped, for lack of better words. Yeah, it's been really helpful. It is ideal to have the first visit and sometimes follow-up visits if there's a change to be in person. So if that's possible, that's really great, because headache can be a symptom of something in your brain or something in your body. You do have to kind of lay hands on people. And I mean, neurologists have the coolest exam. You have to admit. You can do a good part of it through the video. And I have found facial droops, and I have people bring their eyeballs really close to the camera, and you can see some things. But yeah, so that part of it is lacking, and in some cases they just have to come in. But yeah, I've been able to see patients all throughout the whole Northeast now. We have a system in place where I can see anybody in our VISN 1 and also VISN 2, and the VISN are these networks where the VAs kind of clump together. So VISN 1 is the Northeast, VISN 2 is New York and New Jersey, I think. And so we have contracts so that we can see anybody there. And because even though the medical record system is a little old and sometimes clunky, it goes back to the early 90s. You have every single visit. You can find things that I don't expect patients to know, that they, have this finding on an MRI from or from a CAT scan from 1995. So I actually really like that factor. And so I have both now. I have a telehealth clinic and a face-to-face clinic, and it's not going away. It's only going to stay.
Oh, so Kate lives in Virginia, so she'd be able to see you through telehealth?
No, she could eventually see me. She would first have to be referred to the closest headache center within her in her area, and then should additional more assistance be needed, then she could see me. So first goes to the local and then to me.
Okay, that's good to know. Yeah. So going back to the veterans, so, we've heard, a lot of the treatments that Dr. Schindler and Dr. Seng was talking about. So what do you use for your self-care, like in your treatment plan? Who wants to start?
I I think I've already said I use marijuana. I use again, it's because I haven't, the last time I went to the VA, they took my migraine medication and replaced it with Tylenol. So I use napping, cold compress, whatever.
Okay. So how come they took away your migraine medicine?
They said that that was one that they no longer use. Maybe it's an older medication. I'm not sure. And
was it helping you?
Yes.
Okay.
They were under control. My migraines were under control. So I just wasn't willing to go through a whole bunch of medications to try and find one that worked.
Okay.
That's on me.
And so what about medical cannabis? I mean, in the VA system, because, it's legal in some states, but yet VA is federal. How do you deal with that when a veteran comes in and says, this is the only thing that's working for me?
Yeah, so through the VA, I'm not able to actually prescribe prescribe cannabis. You have to have a certain license for it anyways. But within the VA, it's there are quite a few medications that aren't part of the formulary at the VA. So I kind of see it like that. It's something that we can't prescribe. I ask my patients to be very open and tell me everything that they take. Even if I can't prescribe it, I want to know, because I want to know if it's going to possibly interact with something else, or and also see if they're using it in a safe manner and things like that. So I ask my patients to be open. I can't personally prescribe it.
Okay. And Cheryl, what about you? Go ahead.
From a research perspective, one of the biggest challenges has been that it's actually been very difficult to conduct research on medical marijuana use for various kind of regulatory and systemic reasons. But those have actually been lightened this last year. So the hope is that we will, because there are lots of veterans and other, patients with headache disorders and other chronic pain disorders who describe, deriving benefit from using medical marijuana. And it would be so helpful to know why and who, right? So my hope is that the easing of regulations will mean that we can write grants. So that's the first step. is you have to write grants to then do the research, and then we can have some research that can start to guide clinicians in their decision making. Because right now, unfortunately, all I can ask, if one of my patients, tells me, oh, and this is part of my treatment regimen, all I can ask is, does it feel like it has helped you? Because I don't have a lot of kind of, more trials or peer-reviewed scientific information to help guide them and their treatment team. So hopefully that will improve over the next couple of years. And I think that headache disorders are in a really important area for us to be evaluating those questions empirically.
Oh, thank you. Cheryl, what about you? What's your self-care plan, your treatment plan? What does that encompass?
A couple of things. So meditation, prayer, laughter. Laughter is like the best thing ever. I have playlists on Spotify, YouTube of just things that make me laugh. Go to a playground, listen to some kids laugh. But if you're like single by yourself and don't have no kids, it's kind of creepy sometimes. But
you could pretend you're the aunt or uncle.
yes.
Yeah.
I have pain playlists on different things, and these are like songs or movies that provide comfort to me, or they can just kind of take my mind away from what's going on. Also, nutrition. I learned for myself that comfort foods, like warm comfort foods that bring back memories. I know it's not healthy to have Oreo cookies, but baby, sometimes I have an Oreo cookie headache, you know? Sometimes that's what the doctor prescribes, or maybe a warm soup or something. But just over the years of like learning those things, I also have a vision wall in my bedroom. So the days that I cannot get out of bed, I can look on my vision wall and I can see like consistency. I can see the words push through, or I can see the word dreams. And then I also have like lists of dreams that I want to do. And when I'm laying in bed, I'm like, and I learned to give that headache the middle finger, because headache, when I'm done with you, I'm going to Thailand. I'm going to, and just being able to do that. Sometimes I stand in the mirror naked and cry.
Yeah.
I don't know if I'm crying because I got COVID body or I'm crying because of the headache, but something about, and talk to myself like.
Thank you so much.
Well,
Yeah.
I'm so sorry. This is Nicole Hemingway. I know I'm a voice from above right now.
Oh, yeah.
The CEO of US Pain Foundation. This has been such a wonderful discussion. And I didn't want to have to cut everyone off, but we do have quite a few questions and we are running low on time. And so first off, to all the panelists, thank you so much. Your answers were honest and candid about your personal experiences. To have Dr. Schindler and Dr. Seng here, thank you for bringing that insight and knowledge and wherewithal to all of us so that we better understand how we can advocate for ourselves and the Headache Centers of Excellence, and how important they are to the VA program. And Gwen, thank you as always for being so great at moderating. But I did want to get to a couple of the questions. And so one of them is actually around the Headache Centers of Excellence. Somebody wrote in saying that they don't have one near them. Can they get the same care for migraine at a VA, or how do they advocate so that hopefully an HCOE will show up in their area soon? And I'm not sure who wants to start that one, Dr. Seng or Dr. Schindler.
Yeah, I can get started with that. So we are working to have more. The map I showed earlier was an older map. It only had 3 of the consortium sites, and now there's seven or more. So we are looking to add those sites who have headache specialists, or those who have been seeing headache patients for many years and who do have expertise. So we are working towards that. In the meantime, if your VA, as was mentioned before, headache care, it often starts in the primary care office. So let your physicians know that you have headaches, and then from primary care, if it can't be managed there, then it goes up to neurology, and through either primary care or through neurology, a referral to the local headache center can be made, and that'll start with the telehealth visit. Like I mentioned before, I've been seeing patients all through the Northeast, and that's typically with a telehealth visit. So there is a way to once you're seen, to be referred out.
Thank you. Yeah.
Great, thank you. That's very helpful. Another question that we received, and this was about post-COVID long haulers who now have chronic headache attacks. And they were mentioning that the VA doesn't have any post-COVID syndrome clinics or care centers And would they be able to receive care for the chronic headache attacks through the Headache Centers of Excellence, or how do they receive care?
I've seen several patients who have been having headaches. We don't have a separate clinic for the COVID patients. We see everybody. So I have had referrals for patients with these headaches. And so it would be the same mechanism.
Okay, thank you.
And even outside the VA, this is a lot of post-COVID long haulers are increasingly being seen in neurology clinics, and often neurology clinics who have headache subspecialists on staff. So I think that's a really consistent clinical approach for trying to manage COVID long haulers, both within and outside the VA.
Perfect.
So,
Thank you.
so if there's a waiting list at your centers, will you refer out? Can you refer out?
Yes. So, and this is not just for headache. This is for any subspecialty care. If the wait is longer than 30 days, or if someone lives too far away from their VA, they can be referred to someone closer or someone who has a sooner appointment. Yeah.
Good. Thank you.
Another question was, why are women more likely to get headache?
So that's there are several levels to that. So first off, headache. So having a headache disorder, it's a genetic condition. So, and let's just, and we can use migraine as the example because that's the most well studied. That is more common in women. And the onset is usually around the time when there are hormonal changes, and the offset is usually when there are hormonal changes. So people start to get migraine in their during puberty, and then after menopause it goes into remission. So it's probably hormonal related to some degree. And even the individual headache attacks, they can come on based off of fluctuations of hormones as well. So that's one major factor. In terms of post-traumatic headache, so anyone who gets knocked in the head or has a large force going through their head, such as being exposed to a large blast, can develop a headache disorder. Part of what we're currently studying is it also comparing men and women with post-traumatic headache. How are they different? Because we need to know, and at this point we don't know. But using migraine as the example, probably in some part hormone related.
Thank you.
Perfect. Thank you. And we have about 3 more questions. One question was regarding the large number of headache disorders, and do physicians regularly learn about them during medical school curriculum, or is that why individuals should really try to see a headache specialist?
I love your
And
smile.
I see both,
Dr. Schindler.
exactly. And Dr. Singh is doing the same.
Yeah, Dr. Seng. Yeah.
Yeah. I kind of show that table of context for shock, like a shock of, like an effect, because there, it's so headache medicine is typically not been taught very well in med schools. I don't have the exact numbers, but compared to how many hours
there are 4 hours. I've got the
you have
exact
it.
numbers
Okay,
for you. Oh yeah, this is
Right.
part of what we do. So there are 4 hours in medical school required on pain as an entire
Pain. Okay.
group. So headache is part of that. And as I'm sure Dr. Schindler is going to say, neurology is really where neurology residency is where most people get their first exposure to that particular list. And different neurologists may decide that list is really important and some may not. So the UCNS certification for being a headache specialist is a way to make certain that the person that you're seeing in front of you has spent quite a lot of time with that list and has a very good understanding of the ins and outs.
Yeah. Yeah. So yes, I've now forgotten the amount of training. So yes, there is not enough training on headache or pain in general. And so those who happen to have an interest in headache, such as myself, just dove deeper. Headache medicine is not a particularly popular subspecialty. Like I mentioned, there's only like 2,000 in the whole country, but it is becoming increasingly popular, which I'm happy to hear. But we still need a lot more headache doctors and a lot more neurologists too. Just in general, neurology is not the most popular specialty. But again, because we have so many new treatments coming out, and because we realize that not every treatment involves drugs, the more we can incorporate other factors, I think people will be more and more interested. So yes, we need to do better.
Thank you. This question is now for our veteran panelists, and it was, how do I continue to deal with headache? And if you have any tips, headache or migraine disease, if you have any tips on how you handle it, or something that offers them encouragement. And Kate, I'll start with you.
Well, I've already said how I handle it. And if you're not in a legal place, don't handle it the way I do. Handle it the way Cheryl does. And I would say, keep in mind that hopefully tomorrow will be a better day for you pain-wise.
John, what about you? What were you drinking, John?
Have you tried drinking water? If one more person says that to me, I'm going to snap. One thing that helps for me, obviously the Botox injections work great for me. I don't know if they'll work for everybody, obviously, but the other thing that works very well for me is heavy carbs. Once I cut pasta and breads out of my diet, my migraines cut greatly. I still get them, but they got much better. Now if I eat a big bowl of pasta, I don't think I have a gluten allergy because I can eat all kinds of other stuff. But if I eat a big bowl of pasta or something like that, I feel like I got a hangover the next day. I'm miserable. But watching my diet helped a lot, especially if I go full on. I'm a big meat eater. I love steak. If I eat a lot of red meat, I feel a lot better. But yeah, that and water. Drink lots of water, apparently. That's what everybody always tells me.
Cheryl, what about you?
The key is finding humor and compassion, being compassionate to yourself and knowing you are not alone in this. I think for me personally, I felt like there was something wrong with me up here because my pain made me feel like I was going crazy. I was delirious. But once I learned that there was a reason for my pain, and then to be compassionate, like, I'm okay, like, and this too shall pass. And if you can find a support system, like I have different support systems I have different friends that I can complain about different things. Some stuff I can't talk to my mom about because she want to feed me, right? Or, some things I can't talk to this friend about because she likes to cuss. So just being able to find the support system that works for that particular need and not overwhelming them, but just things that bring joy. Find those small things that bring joy to you, even if it's just 1 minute of joy. Like literally some days I'm like, well, Cheryl, if you can just get through this next 10 seconds, you'll be okay. And just talking myself through that 10 seconds. And then the next thing was a minute and so forth.
Yeah. And one major way of getting support is US Pain Foundation. We have a new group called Basic Training for Veterans with Pain, which Kate leads. It's the first Thursday of the month at 8 p.m. Eastern Standard Time. So please join us. And wait, so the next date will be the 1st, July 1st. So please join us on that one. Yeah.
That's a lot of fun and a lot of fellowship. That's one way to forget your pain, at least for an hour.
Yeah. Okay. So thank you so much, everyone, for, really sharing, what you've been through and telling us all the up-to-date, treatments that are out there. We really appreciate it. I know we could have spent another hour talking about it. So we just want to acknowledge our corporate sponsors, for helping put on this panel, and it was developed independently. And a few announcements. Yeah, basic training for veterans with pain from 8 to 9:30 ET. And please register at painconnection.org /support-group/ and look under specialized groups. And the next issue of the Invisible Project is set to be published soon. And please go to invisibleproject.org to see all the previous editions. And this was also sponsored by electroCore. So thank you again so much. And please sign up for Kate's group. Okay. And Cheryl and John, you need to be there too, to give her support. Okay. Thank you, Dr. Schindler. Thank you, Dr. Seng. Thank you, everybody. It's been a pleasure. Night, everyone. Bye.
Good night.
Bye.